Behavioral Health, I'm sorry, welcome everyone on behalf of the Douglas County Criminal Justice Coordinating Council and also the members of the Behavioral Health Leadership Coalition. My name is Bob Tryansky. I'm the Director of Behavioral Health Projects for Douglas County, and we'd like to welcome you tonight to this evening's listening session on 988 crisis call centers and mobile response. The Criminal Justice Coordinating Council is seeking new ways to engage citizens' ideas, feedback, and lived experience in its work. And tonight we would like to hear from you. The Mobile Access Work Group will provide a brief explanation of their work, and then we'll take responses from you. Your responses will be summarized in a report to the County Commission work session on May 5th, the CJCC meeting on May 11th, and will be utilized by the Mobile Access Work Group as our work continues. As everyone knows, in 2017, Douglas County undertook a major initiative to improve behavioral health facilities and services in our community. Much of that work was focused on and has been focused on the development of a treatment and recovery campus for Douglas County that includes the crisis center that you see behind me, the rendering of the crisis center, as well as 3 tiers of supportive housing all in one location. A lot of energy has been put into improving our crisis continuum, but one of the things that our behavioral health partners and our criminal justice partners all know is that facilities are not the answer to meeting the needs of people who need care, who need help, and who need treatment. And so what we would like to share with you tonight is some planning and visioning that's been going on around some additional components to add to what would become an integrated system of behavioral health care. And one of the components is, 2 components we really want to look at this evening is a 988 crisis call center and a mobile access team that would respond to people in the community when the crisis center's front doors are after hours. We'd like to just turn to a short video just to give you an overview of what a comprehensive crisis care system looks like. And then I'll introduce our panelists and our host and moderator for the evening who will lead us through our discussion.
I think we may need to share the audio.
Sorry about that, folks. Give me 1 second to do the audio share. All right, Monica, what am I missing on doing the audio share here?
So when you are sharing your screen, if you kind of click down on view options, you're looking for the little microphone, and you should have a little arrow that clicks down and it says share computer audio. Anyone else who?
And you may have to stop sharing and reshare, Mike. There you go.
Hey, Monica, I could not hear you. Bob, do you have the video pulled up? Can you share it?
Give me 2 seconds. Sorry about this, everybody. Perfectly well in rehearsal. Are you all able to see that screen?
Yes. Yes.
Imagine for a moment that a fire breaks out in your home, and in this reality, 911 doesn't exist. You might call the fire department directly, but they're not equipped to come to your location and only put out fires at the fire station. And the only people that will come to you in the community are the police, who, though well-intentioned, are meant to provide a very different type of public service. This lack of a fire-specific response seems ridiculous, right? Of course we should have targeted services to respond to life-threatening emergencies, whether that's fire, law enforcement, or physical health. However, in many communities across America, life-threatening mental health and substance use crises are treated as an afterthought, receiving a response that's not specific to their unique needs. A 911 call dispatches the police, who most often bring the patient to a medical emergency room or jail, or allow them to remain in the community but without assessment, treatment, or support. We have a patchwork system, made up of elements designed for other purposes, that doesn't have the capacity to treat the most vulnerable in our communities, even though an estimated 20 to 25,000 individuals in crisis go to emergency departments every day in the US. So how can we improve? The only solution to delivering crisis care worthy of our communities is to build a structure specifically for mental health, substance use, and suicidal crisis that is on par with other emergency systems, like we do for medical, fire, and law enforcement. By integrating 3 core elements, we can replace the patchwork fabric of our crisis care and develop a true safety net that can serve everyone, everywhere, every time. And in the process, we can reallocate wasted financial resources to places where they can have a deep community impact. It starts with regional or statewide crisis call hubs. Call, text, and chat lines staffed by trained professionals who answer the call every time and direct people to the level of care they need. The onset of 988 is a great start. However, it will need to be supported by technology that empowers 988 to become an air traffic control for mental health and substance use crisis, enabling real-time coordination across the care spectrum. But a comprehensive crisis network cannot be built with only crisis call hubs. Additional services are necessary to ensure that a unified system of care is available when and how people need it. Services like mobile crisis outreach teams, 24/7 non-law enforcement mobile teams that go out in the community and deliver care to people wherever they are. This lessens the burden on law enforcement during situations where they're not needed and eliminates the anxiety people feel when a uniformed officer knocks on their door. And facility-based crisis receiving and short-term stabilization, facilities that say yes to every person that walks through the door, regardless of their level of need, allowing them to bypass the medical emergency departments. This not only provides specialized care to these individuals with less waiting, it also enables medical emergency departments to focus on the patients they're trained to serve, while drastically reducing wall time for police when transportation by police is warranted. With these core elements in place, mental and substance use healthcare can move out of the shadows and into the mainstream. Together, we can build an unbroken system of care that connects patients from the point of crisis to the level of care that's right for them. To learn more, visit crisisnow.com.
So we've been meeting for a number of years to stand up the treatment and recovery campus of Douglas County. And about a year ago, the Criminal Justice Coordinating Council formed a work group to look into the possibilities and the opportunities that exist for call center and for improving our mobile response. The co-facilitators of that work group are Stacy Cooper and Monica Kurtz, and I'm going to turn it over to Stacy. Stacy's the Director of Case Management for Heartland RADAC, that's Heartland Regional Alcohol Drug Assessment Center. She is one of the mobile access co-chairs, and she's going to share how the work group has been operating for the last year or so. Stacy?
Yeah, thanks, Bob. Like Bob said, I'm the co-chair of this work group. The Mobile Access Work Group is really a joint work group with the CJCC and the Behavioral Health Leadership Coalition. And the goal of this work group really is to improve access and coordination of crisis services in the system of care within Douglas County. I'm just going to send this over to Monica. I think that she could start speaking to that. Monica is the Vice President of External Programming for the Kansas Suicide Prevention Headquarters, and she also co-facilitates this group with me at times. Go ahead, Monica.
Thanks so much, Stacy. So you all saw that the video referenced a call center hub, or as we refer to it, an air traffic control center for crisis services or behavioral health services. The Kansas Suicide Prevention HQ will be presenting a proposal to utilize the quarter-cent sales tax to provide the Air Traffic Control Center service with the support of the Emergency Communications Dispatch and the Burt Nash Access Center. So KSPHQ is an NSPL center for all 105 counties in Kansas, and will be one of the 988 centers when our 3-digit mental health and suicide crisis line goes live nationwide July 16th of 2022. And so I'd like to introduce the CEO of Nash, Patrick Schmitz, to talk about the mobile team component of the proposal.
Thanks, Monica. And thanks all of you for joining us tonight. I'm really pleased to hear your input and your ideas and feedback on what we're doing here. Been really excited to be part of this community for almost 4 years now, and we're doing a lot of work. And one of the exciting things I get to share with you tonight is that the Burt Nash Center is proposing the expansion of our Access Center, which is where people come in to start services and for crisis work, to begin including a mobile team who can respond in the community where services are needed. This pilot will also use some of the quarter-cent sales tax funding, and we will start with weekend coverage. The team will work closely with KSPHQ's Air Traffic Control Center. And so really excited about that. And I'll really honored to introduce Alex Kimball Wilson, the Health Equity Planner for Lawrence Douglas County Health Department, who will serve as our moderator this evening. Alex?
Thanks, Patrick. Yeah, so I think that it was interesting being asked to help facilitate this group. You know, I have a little bit of background in a little bit of legal studies, definitely research, definitely you know, looking into police brutality and a lot of different various community organizing topics with folks. And I got a chance to meet people from CJCC this year in my position at the health department. Got a chance to meet some folks and kind of hear what they do, see some presentations of some local jail and prison statistic data that I thought was really interesting. So yeah, I think that it's really important to hear community. You know, anytime that people are in a group making decisions and making moves in a community, it's really important to listen to people that have that lived experience. And even if you don't have any direct lived experiences, a lot of us may have friends and family or just ideas and feedback in general. So we would definitely like to hear from you tonight. The goal of this is to listen and to take ideas. If you have questions, specific questions, we also welcome those, although we definitely want to leave as much of the floor to the attendees to speak, as opposed to the people here tonight engaging a whole lot. But yeah, and then also please practice lean speech so that everybody gets a chance to speak. That would be maybe 3 to 5 minutes. And then of course, if we go around and not everybody has a chance to share, we will schedule a second listening session because we don't want to cut this conversation short. You know, we don't want to leave anybody out, but we also want to respect everybody's time tonight. It's the evening hours, and we want to make sure that we're keeping this to an hour if we can, just to kind of respect everybody here. But again, if we don't get through everybody, we will schedule a second listening session. So Mike is going to be kind of co-facilitator tonight, and let's see. Would you mind? I think the chat might be disabled. Let's see.
Yeah, I went on to make sure the chat was ready to go. I don't see it.
No, it was ready before the meeting. I saw it. So
Okay, let me work on that. If we have someone that wants to talk by voice, we'll go with that first.
Right. All right, well, while we're getting the chat abled so that people can type if they're more comfortable, or if it's just easier to type into the chat. If anybody would like to unmute themselves and share their thoughts or questions verbally, feel free to do so.
Can you repeat the questions? I mean, what is it you want us to respond to?
Yeah, I think that the goal of the listening session is just people's responses. You know, it could be to the ideas presented in the video. It could be what the Criminal Justice Coordinating Council, their work, things that you'd like to see in the community in terms of behavioral mental health and substance abuse or substance use implements that we have in terms of solutions locally.
I have a question. This is Chris Flowers. Why does there need to be like a 988? How come 911 can't just send it to the mental dispatch place, I guess? Also, I think we should be trained in 911 like they should be contacting the mental health, because like a few months ago I was delivering, and there is this what I thought would look like, I would have guessed, the black homeless guy, and he was in the neighborhood. He's like looking in mailboxes and then dropping down to the ground and kind of like crying. And I didn't know what to do, because I wanted to call 911, but I didn't want the police coming out to deal with him. And anyway, I'm just thinking, what about people who do call 911 for this? Because in the end, he ended up coming to me, and he got in my car, and he wanted a ride. I guess he was drunk and lost, basically. But it was something that like a mobile mental health dispatch team that they showed in the thing, that would totally been what he needed. And I would much, because I was just thinking also, it's kind of like how we have a no-kill animal shelter, and because we have that, I'm more likely when I come across like a lost cat to take it to the shelter, because I know I don't have to worry about them killing it. So I kind of want the same, where I can call 911 and not have to worry about police killing someone, or just taking a homeless person into jail. So that's just my thoughts I wanted to share. Thank you.
Thank you so much, Chris, for sharing. I think that's a really great start to the conversation.
Could you provide a little more detail about what is going into this application? Exactly what are you proposing, and how will the funds be used?
All right, any of the panelists?
I'd be happy to speak to the crisis call piece of it, and then I can maybe toss it over to Patrick to talk about the team. Is that agreeable? Yeah, thanks for the question, Rick. So we have really, as a work group, kind of identified the two components that we're talking about this evening. Currently, KSPHQ provides a 24/7 crisis hotline that anyone in the community can call. You can call right now, and we are able to offer, really some collaborative listening and problem solving type crisis counseling that we find to be effective. Really in de-escalating and safety planning the majority of callers who contact our hotline. What we're proposing with this new proposal is to really do one thing, which is to ensure that we have enough folks in the call room to answer every call that comes in. And second, to build a more robust referral system with our behavioral health partners and other social service agencies here in Lawrence and Douglas County. So right now, when a Douglas County resident calls the hotline, we're able to provide contact information for a lot of the really great partners that we have in this community who provide excellent services. But we don't have the capacity to do warm handoffs, where we think about really being able to pass a caller directly to someone who will be the next helper, or to make really kind of tight connections and referrals to our behavioral health partners. So that's a big part of this proposal, is building the capacity within the system to ensure that, like an air traffic control center always knows where a plane is, that we have someone in the community who's really able to be that connection point for the person in crisis until we've handed them off to someone who can do some longer term treatment or problem solving with them. The other component of that would be the dispatch, which we've talked about. So when the mobile access team comes online, we essentially grow another tool in the toolbox for folks in crisis in the community, and would be able to dispatch that team. if that answers that portion of the question, I'll pass it over to Patrick.
Sure, and then that's where we step in with the extension of our access center. Our access center right now, people can come in crisis and we will work with them, but it's not available on the weekends and late into the evening. And so we will, part of our proposal is to hire two therapists, a case manager, a peer, and then a program manager who can oversee things and really is part of the team. They will be available Friday, Saturday, and Sunday from 2 until midnight, and then another 10 hours yet to be determined. So they will be available to be deployed when air traffic control says, hey, we have somebody who you need to go out and see at this address or on the corner of here or wherever they're at here in Douglas County. And that team, some makeup of that team will go out and intervene and help assess. And what we know from other places that do that, we will be able to handle a significant number of issues right there in place, be able to say, okay, we'll check in with you tomorrow or whatever the agreed on time frame. And only a small number will actually need to go further into the system, such as to the crisis center when it comes online. So that's kind of gives you a little bit more of a framework, Rick. Thanks for that question.
Yeah, and just to follow up, if you could say a little bit more about what the relationship is between the mobile access team and the CIT and co-responder folks. How would you differentiate the work that you're going to be doing versus the work that they're doing?
Our team does not include a law enforcement officer, whereas the co-responder team does have that component to it. The CIT is the training that the law enforcement officers take to help them be better prepared and give them better resources when they're dealing with somebody who's in crisis. And it may not be a mental health crisis. If you're interacting with police, it's possible it's a pretty stressful day. It gives them better tools than just how to help everybody. So that's kind of the difference. This team will not have a police force with them. Just like in the video, they just show up looking like everyone else.
Thank you.
No uniforms.
Rick, also there's on coverage, the co-responder unit in Lawrence is available Monday through Friday from 10 to 7. And this team, as Patrick was sharing, would be available 2 to midnight on the weekends and then some additional time. So there's some overlap there. This team also will extend its outreach to the other municipalities beyond Lawrence. So that's another piece of the difference.
Thank you.
Thank you, Rick. Really great questions. I think that helps clarify for a lot of people who may not be familiar, I think more familiar with what's available. And huge thanks to the panelists for engaging that question, I think, for everybody.
Alex, it looks like Caitlin has her hand up.
So I just wanted to jump in. I've got another meeting that I've got to go to, unfortunately. Everybody likes to schedule on Tuesday nights, apparently. But I just wanted to say that this is certainly a long time coming in this community. For some of us who have really wanted these kinds of services and really needed them for our family members. It's critical that this happens. And it's come too late for some people. And I just want to thank everybody for doing this work and to really encourage you to make this happen, because it's a huge hole and it needs to be filled. So thank you.
Thank you, Caitlin.
Yeah, thank you, Caitlin. And I do want to acknowledge that there has been loss, and to express my sympathies for that. I have some familiarity with what it's like to try to navigate a mental health crisis with someone. So thank you for being here.
Yeah, thanks so much for sharing your own experience, and I think the real need for some type of alternative from what's currently in place.
Alex, Marielle Pereira's hand is up. If that.
Okay, I'm going back and forth at the screens here. Marielle, awesome.
Thank you, Alex. Thank you, Darren, as well. Hi, everyone. My name is Marielle Pereira. I'm actually a part of the CJCC as the District 3 representative. So I'm also new and a part of this work group. I have not been able to attend a meeting yet, but very excited just to hear about the community push for crisis intervention and crisis management. I think that just like the two folks before us, the individual before me, excuse me, expressed that this is something that's been needed, and just thinking of the individuals and lifting those up who did not receive this kind of care, especially just very excited to see how we move forward with this. The question I do have, or that I just wanted to speak into this room, pertains specifically to communities of color. And if there is a specific, I know at this point we're in our early stages, but is there a plan to start having community discussions or planning within our work group, within CJCC, to address the needs of specific marginalized populations? Because as we know, typically those are under-resourced and underserved populations. And I think it is imperative that we reach out to them. Also, being a community member that does crisis intervention and truly does not rely on police intervention with that, I really think that that is something that we should hold a value. So that is my question or discussion point for the work group that I'm in. So thank you.
Thanks, Marielle, for sharing that. I think anytime that projects or things that receive funding get put into place, it's almost as though marginalized groups are the afterthought, and it's, how do we make it fit them after it fits the default, right? And so, yeah, very, very good point.
This is Patrick. I would say that, the work that the Racial and Ethnic Disparities Work Group of the CJCC has focused on that, but more on the criminal side. But I think this would be a good addition to that. And so at our next meeting, and Mike's part of that, happy to bring that forward and to say, hey, this needs to be on our whiteboard and parking lot watching it. And actually, before everyone joined, we talked about doing some more listening sessions, and that would be a perfect way of doing this. So thank you.
Thank you. And I'm also more than happy as kind of a new person in that group to kind of help facilitate and have those discussions. So I'll make a mental note. Thank you, Patrick.
And I wrote your name down, so you're on the list.
Thank you.
I wanted to follow up, Patrick, with you on the last exchange about CIT, because as I was listening to Monica, I got the distinct impression that the mobile access team would function as a result of calls coming into headquarters, and things would kind of move from there. So it seems like the array of services that you're offering or proposing to offer through mobile access team might also be of interest to some of the calls that CIT officers and co-responders are getting. So I want to just kind of hear a little bit more about what that relationship might look like.
Sure. That I think in those cases where law enforcement shows up first and they determine that maybe the best use of their time and the best intervention for the individual would be that mobile access team. That's one of those details we have to figure out is how do we get them to be able to mobilize that team and call that team out. And so we will be working on that. We've seen that work in other communities. And so we just have to, some of those details that we will, like I said, we'll work out here in the coming weeks. But there will be a good coordination, and law enforcement, fire med is part of this team in helping us talk about those very same issues.
Good, thank you.
Yes.
I'm just mentioning, it looks like the chat is enabled now. So for folks who would prefer to, maybe type or think about your feedback or your question in the context of chat, feel free to do that. We'll definitely save the chat, so we'll have all that there as well. But yeah, feel free to utilize the chat. I'll be keeping an eye on that as well.
Patrick, I'll just say one more thing, and very much like in the video where it said, let's create a crisis center that says yes to everyone. We want to create a system that says yes to everyone and gives them multiple ways to access these services, because we want them to have the best and most effective intervention for them at their place at the time. And I can't remember that great little phrase inside that video, but the right service at the right time, the right place, something like that. And that's what we want to work towards. Rick, you asked about launch time. I think that'll be dependent on how we were able to move this forward with the support through the Board of County Commissioners. But I believe, and someone might want to correct me, I think we're shooting for late this summer or early fall. I could be wrong. That might be my ambition, but I think that's it. And I just got confirmation that that's it. So late this fall or summer and early fall.
Thank you. Really great question.
Alex, can I jump in with a question? Sorry. So Darren Kennedy, and I'm on CJCC. Patrick, my question isn't in response to something you just said, but it's to anyone sort of on the panel. I actually would love to know a little bit more about what does it mean to say yes in terms of practice and action, and I know that's a little bit of a woo-woo question, so to kind of perhaps provide a gate in, I think when I think about listening sessions, a lot of times it's important for community members, and I include myself here, to know what the initiative is responding to, and to the extent that I know, without sort of leaning into telling stories of trauma per se, kind of thinking, when someone is being told yes to, what are those gates, what are those options, and what is it that we're hoping to solve as well as part of maybe the other portion of that question.
Not sure if anyone else wants to start. Bob, do you want to start, and I'll jump in after you?
Yeah, let me see if I take a crack at this. I think that those of us who live with a serious mental illness, who have dealt with an addiction issue, have been at a moment of crisis, have probably experienced times where the system says no for varieties of reasons. And so when we say we want to be able to say yes, the idea is there should be no reason to turn somebody away at the crisis center. Not only should we say yes, but we should welcome people when they come back. Not only should we say yes when law enforcement drops somebody off, we should encourage law enforcement to bring another person or to bring the same person back when they need care. We're trying to build a community ethos around supporting people with behavioral health concerns, with the idea that they live in a community where their care is, it's an essential priority. And it's no different if you need behavioral health care than if you are having a heart attack and you need a cardiac emergency response. So, the consultants that have been working with us, not just designing the crisis center, but also our crisis continuum is, our highest value should be take the patient, just take the patient, regardless of their housing status, their income status, their insurance status. We say yes, and we do that, and we want to extend that ethos into community response. So I don't know if that answers the question or not, Darren, but I think at a high level, it's building, integration among our partners, that we share this value that says we will deliver the right care at the right time in the right setting, regardless of circumstance.
I see there are other questions. I will just say, yes, that does answer the question. And for my 2 cents, I really love your response, Bob. And it is, in to your word, an ethos that I completely agree with. I just hope, I want to challenge us all to lean into that, because Kansas's culture and the culture of a lot of institutions is to do gatekeeping, to find ways to say no to giving out services and in some cases there are a variety of reasons why. And so I'm not saying that there are bad or evil people, but I do think the culture of yes that you're describing is still potentially a sea change. It's a sea change that I would support and get on top and on board of, but that that narrative and that way of proselytizing that you just did, I think there's going to need to be a lot of that, for what that's worth.
Thank you so much, Darren. Always nice hearing you speak. It looks like Sherilyn Wells has their hand up.
I'd like to say I think this sounds very good and is fact very different than I perceived the mental health system for quite some time. I have seen people that desperately needed help in this community that were labeled treatment resistant, non-compliant, and I felt like reasons were used to justify not giving them any help. And things like, well, we've got to wait until they hit some kind of bottom and then they'll become more pliable for treatment. But that absolutely does not work. I mean, they just get worse and worse. And I have also felt like maybe it's changing a lot, that the attitude towards people that have drug and alcohol problems was not that sometimes it was considered a treatable illness, but then it would flap over into being a moral failure, and that people were deeply stigmatized by people treating people like that as though they were a big failure. And I have witnessed treatment providers talk like that, and I found it very disappointing.
Thank you for sharing, Sherilyn. I wanted to make sure that you were done. Yeah, thank you so much for sharing that piece about, almost as a little bit of follow up to what Darren was speaking to about, there's a culture, I think, around the approach that also needs to happen. There's these solutions and things that are being planned, but then, on an individual basis with providers, what is the difference being made? So thank you for sharing that. In the chat, I'm looking, someone is sharing about a family member with autism and significant mental health issues, and how the presence of police can actually be triggering versus helpful. I think it was it Bob? Were you talking earlier about how that even if someone does not typically experience behavioral health differences and things like that, that sometimes just the presence of police can induce perhaps a need for the service as well? Is that you?
I don't know that. No, I don't know that I said that, but let me see if I can take it. I'm not sure I'm following. I think the idea is One benefit of this approach is that if law enforcement are not an automatic part of a response, that you'll be more likely to not escalate somebody on site. And there's certainly a lot of benefit and advantage to that. But also having a trained team who's sensitive to all the types of things that can escalate and trigger somebody, and being ready to calm that down, understand where that's coming from, keep everybody safe, and to be able to make progress on getting our community member the help they need, and to make sure that they're engaged in a caring process. Does that speak to it?
Yes, thank you. I was curious, and then also the person's comment in the chat kind of made me think about all the potential uses for that. So thank you.
So Patrick, I would add to it is that the part of the goal of the team is to be really well versed in the variety of etiologies that might create what sometimes looks like a mental health crisis, and it might not be a mental health crisis. It might be something else going on. And so we will want this team to be well trained in being able to identify maybe this is some component of autism or an IDD or something else. There will actually be substance abuse professionals as part of this team, trained, who can help that team better assess an individual if that's what's going on. And so it really, our goal, and it may not happen immediately, but that long-term goal is a team that is really well versed at going into the community and really having a positive impact across most every situation. Now, it's not going to be every time, they're not going to be perfect every time, but just more often than not, getting better and better at responding well.
Thank you for the clarification on that about the applications of this, and maybe what some of the extra implements might be, like within the solution, that there could be these potential positive benefits as a result of that. Another question in the chat is, so let's see, can the panel speak to the capacity limits for crisis response and other services? Rick says in the question that he's aware of the staff shortages that there may be, and I think maybe he's curious about the capacity.
That's a realistic concern, Rick, and that is something we Bert Nash and DECA and Heartland Radak and KSPHQ and all of us are really looking at is how do we build this mental health workforce that's going to be able to do this work here over at the crisis center. We as a community have to take a very serious look at how well we take care of our mental health professionals and be able to attract and retain them. That's a realistic thing. That's why this is going to start out as a pilot, not a 24/7 operation. We want to get it started and see how that goes and then expand from there.
Awesome. As a kind of a follow-up question, Kirsten in the chat asks, how large will the team be?
So on the mobile access team, our intent to start them is going to be a 5-person team. Now, not all 5 are going to go out to every crisis, but it's going to consist of a program manager, somebody who kind of oversees them and gives them the support and supervision and additional ideas and suggestions. There'll be 2 therapists, 1 case manager, and a peer, and there will be a combination depending on the situation, who goes out at what time and to whom. And that team, again, would hopefully grow over time. So we have the ability to respond across a variety of settings.
Thank you, Patrick. Another question from the chat, I'm just going to keep them coming, is have different points of accommodations or access for contact been discussed already? And it sounds like Taylor's talking about for providers and participants or people calling in. She gives some examples about mobile phones, text features, translation, etc.
All right, Taylor, I think I understand your question, though if I don't answer it, please feel free to correct me so that I can answer it. At this point, what we are talking about with the crisis line, the crisis call center hub, would be a voice line contact. So we would have the one primary channel. Text features at this point have not been discussed as a part of this project. There would be additional costs associated with adding text capability to the line, which is not a part of the current budget. With regards to TTY and translation services, as a part of the NSPL network, the National Suicide Prevention Lifeline Network, our call center does have access to both translation services, and then there is a TTY line that is also available. So folks can get a hold of us through mobile phones or landlines, but we would have folks within our building taking those calls. We find that it's important to have folks in a central location so that we can offer the kind of supervision and support that's needed to navigate any call that comes in. So our counselors are highly trained and well-versed in the different kinds of scenarios that folks are experiencing when they call a hotline, but we do think it's important that they have the support of the staff there when they're on the line. So does that answer that question? Okay, thank you.
Really great question, Taylor, and reminds me a little bit about what Marielle was talking about what maybe different kinds of patients, prospective patients would need in different situations. So really great question. It looks like Kirsten has another question in the chat. How long will the pilot of this be?
I think a lot of that, and I'm going to let Bob help answer this. Our initial proposal is for us to start it this year, and I know we've put in our request for 2022 to be able to continue this and expand it. A couple other things is that we are also looking at other ways of helping support and fund this outside of the sales tax. We have opportunities to look at a SAMHSA grant that may help us extend and expand this a bit. There's also in the future what was just passed and signed by the governor last week, the certified community behavioral health clinics, and a component of that also includes some mobile access services. And so we start to pair some of this stuff up. Our plan, I mean, our horizon right now is long-term. I'm not going to exactly be able to say precisely, but we have a long-term vision on this because we know this, as the video showed, this is a critical component to that system of care. And if you remove it, that bridge collapses.
Yeah, what I was going to add to what Patrick said was that, you know, what we're trying to do with all of the steps we're taking and have been taking for the last couple of years and will continue to take in the next couple of years, is to build a system of care that expands beyond where we were 3 years ago, which was primarily outpatient services and emergency department opportunity available, you know, outpatient services available Monday through Friday, 8 to 5, 9 to 5, and then emergencies go to the emergency room, which is the least, you know, desirable place for a lot of people in crisis. So we're trying to go to a 24/7 system of care. We can't build a 24/7 mobile crisis response comprehensively with the sales tax that was passed by the community. We are building and we committed to build a crisis center and make sure that that is going to work well, that the supportive housing is integrated into that campus. And it was always intended that we would experiment with expanding mobile response. So the work group, I think, and Stacy and Monica, you can speak to this, but the idea was, when will people continue to be more vulnerable in the community? And, you know, the data shows that most crisis traffic that goes to the emergency department goes to the emergency department between 4 p.m. and midnight every day. And so people are most vulnerable at about 5 o'clock on Friday till Monday morning because there's no additional response available. We're going to, Burton Ash is getting ready to expand its access center hours to 8 p.m. And we just thought in terms of moving forward, we'll put this piece in place and see what we can learn from that. And that will give us, a sense of what other opportunities are there. The mobile access work group will continue to function after we take the next step, because there are big questions about how to expand that 24/7 crisis response system so that it's as robust and well integrated as it can be in a community of our size.
Thank you.
If I could, I'm sorry, also, if I could just add that the crisis line component will come online 24/7, 365 right away. There is no pilot period. That just turns on. So.
Thank you, Monica. Really great clarification. I'm going to shift a little bit. I know that there's been a couple folks with their hands up. So I'm going to call on Marielle first.
Thank you, Alex. This will just be like a quick comment, maybe a quick seed to plant, since I know we're short on time. And thank you, Alex, again for facilitating brilliantly and wonderfully. And thank you, everyone else, for being in this discussion. One thing I did want to kind of maybe plant the seed for the future is thinking about community groups, grassroots organizers, and folks who are doing this work that are not necessarily fitting the mold of your traditional service providers or nonprofits, and just making sure that those community members who a lot of the time are interacting with folks who are in either immediate crisis or extended crisis, depending on their situation, but who are in constant contact with those folks, to make sure that they are stakeholders in this conversation. I think that's incredibly important to make sure that it doesn't stay in the sometimes traditional hierarchy of only having nonprofits or those service providers be the exclusive access point, and that we have community advocates to be able to help bridge that gap. So it's really more of a comment or something to just think about in the future and maybe integrate into our future proposals or work sessions with this. But again, thank you. I so look forward to seeing this proposal and pilot take off. Thank you.
Thank you, Marielle, for uplifting, I think, the really rich grassroots and community organizing just landscape that we really have here in Lawrence, and the chance to lean on that and for the good of people is always a really, really great suggestion. So thank you. Another person with their hand up that I see was Chris Flowers.
Yeah, I just wanted to ask about, I think it sounded like earlier there might be a plain clothes cop, as part of the intervention or whatever. That's not to escalate the situation, but I was just wondering if they're there for something drug related, will the person be told that the person's a cop? Because they could say stuff that'll get them in legal trouble in front of the cop, or will the cop just be turning a blind eye if he's part of the team to like illegal drug stuff that might be brought up in conversation, whatever?
Yeah, thanks for that question, Chris. There is no law enforcement on that team specifically. If law enforcement come to that scene, it's because they've been asked to in their capacity as law enforcement, probably in a uniform, to secure the scene, make sure things are safe. But on that mobile access team, there is no law enforcement component there, no law enforcement personnel. That again, the idea of this is a team that helps lower the heat for the individual, not increase the heat, the stress, the worry. And again, this team operates at the same confidentiality level that they would if that person walked into our door, or into DECA's door, or Radac's door, or Monica's, the KSP HQ's door. Same confidentiality.
Thank you, Chris, for that question. I think that's very, very important to clarify for sure. Is there anybody else who hasn't spoken yet who would like a chance as we're getting close to the end here? Leaving lots of space just in case, no rush.
Rick had a question if there's any other teams like this in Kansas, and Johnson County has a mobile crisis response team. I honestly don't know all of what it does, but I think we will see more and more of these come on board as more community mental health centers become CCBHCs, that Community Behavioral Health Care Center. And then there's some other initiatives going on currently at the state level that have some mobile components to it that are really in the early stages. So I think we're going to see across Kansas more and more of these crop up and grow.
Great, thank you. Is there anybody else that didn't get a chance to ask their question or give their feedback? Okay, well, I think with Rick's last question, I think that was the last one that I saw in the chat. So yeah, we just have a few minutes left until it's 7 o'clock, and I do believe that this recording is going to be made available. Maybe Mike, you can speak more about that, about how people can find it or the link to it. But I do think that was our intention for that as well.
Thank you, Alex. And I have a quick second. I want to say thank you to the panelists for taking the time and willing to be under the fire on answering questions you didn't know were coming. You've done a great job. Alex, thank you so much for, on a super busy week, agreeing to moderate this for us, because you do such a good job. And then community members, thank you for some of the really good feedbacks. I have some good notes on things that we want to make sure we incorporate. So I will type up a summary of this meeting, and there is a study session with the County Commission on May 5th. And so, which means I have to have this turned in by Thursday, so it can be posted as part of the agenda for that study session. So we'll be working to get that done. We also will be submitting this to the Criminal Justice Coordinating Council. So this will be part of their agenda packet as well, which is on the website. We haven't figured out where we're going to put this on our website, but I believe that's our intention. So that is douglascountyks.org/CJCC hub, HUB. That's the website. Or you can go to the Douglas County KS website, and at the top of the page on the left is a link to the hub. So we'll be getting this information posted. And once again, thank you for your time.
Thank you all.
Thank you so much to the panelists and to everybody that shared tonight. I know it's your time, your precious time. So thanks for sharing with us.